Welcome, my name is Stefan Peterson. I wanted to talk to you about systems thinking today. Um, and the inspiration for talking to you about this today is when I worked in Uganda in the Ministry of Health, improving the quality of children's health care, but found that very few children came to the health center. So we actually went home to mothers to ask them, what did you do last time your child had a fever? Basically with the assumption that the mother would recognize the fever symptom, label it in her disease belief system, and resort to some kind of care. And we found that often, actually in half of the cases, it was home care. So what kind of home care? Well, it was herbs, but a lot of allopathic Western drugs, antibiotics, antimalarial, antipyretics that you had on the shelf that the mother or the parents gave at home. But in half the cases, you sought care for the febrile child outside the home. And then it turned out that in a few cases it was the traditional healers for fever in a child. And again, confirming our suspicion, very few children actually ended up in the government clinic where we were training health workers on IMCI. And even fewer were in the mission clinic, the non-governmental organization clinic, where health workers were also being trained. But the majority actually were in private clinics, drug shops, or shops. That is, the quality of children's health care for malaria, pneumonia, and to some extent diarrhea was actually determined by the mother's interaction with the private sector. So that actually helped me to reflect quite a lot on systems and health systems, and the fact that the health system is much more than buildings and white coats and health centers and hospitals. In a definition that I like by the Canadian organization IDRC, they actually say that the health system consists of what people know about health and illness and what they do to remain healthy and cure disease. That is, the health system is a lot broader than health services and should be treated as such if you want to capture the majority of healthcare actions. WHO actually defines the health system of all organizations, people, and actions whose primary intent is to promote, restore, or maintain health, with goals of improving health and health equity in ways that are responsive, financially fair, and makes the best or most efficient use of available resources. So again, this is broader than the hospital or the health center and the people who went to medical or nursing school. As we then talk about and think about health systems, they can actually be more or less complex, and different interventions can affect the system more or less. If we start down here in the lower left-hand corner, if you're contemplating changing the guidelines for microscopy, when is a malaria slide 1 plus, when is it 2 plus? Actually, the system-wide effects here on the x-axis are quite small, and the complexity of the intervention is also quite small. You put in the guideline, you train the health workers, maybe you change the reporting form, and you're done. While if you're actually thinking about scaling up antiretroviral therapy for HIV and AIDS, it has a lot of system-wide effects, drug supply, health worker training, all sorts of things, and it's actually a very complex intervention requiring trained health workers, laboratory facilities, drug supplies, financing of the whole. So, depending on what it is you're trying to achieve, you need to think more in the case of microscopy guideline, or less rather, or more of health systems effects. For instance, social health insurance, which we talk very much about these days, is a very complex thing to implement, affecting the whole healthcare system. So, how can you then think about the health system? Well, WHO these days like to propose 6 building blocks that are interconnected. That is, governance of the health system at the top here, the steering of both the national system and the local health system, or even your health center. It's having information about what you're doing, health management information system, for instance. It's the drugs and the supplies that we often think about. It's the doctors and the nurses, etc. It's paying for this and collecting money and redistributing money in order to deliver service to the people here in the center. And these are actually building blocks that are interconnected, and if you affect one, chances are you'll affect the other. And therefore, as you now design and evaluate interventions, you need to look at the whole system and these building blocks. So how common is it actually to be doing that? Well, typically we have a tendency as researchers of talking about getting research into policy, GREEP. That is, I did my research over here, I now have new evidence, I want to get it into policy, I want my policy to be implemented and then evaluate my program. This is often a linear pathway, getting research into practice. And possibly that works well for a less complex intervention, changing the microscopy guidelines, if you will, in our example. While as if you're scaling up antiretroviral therapy, chances are you'll need to get research questions out of practice. That is, you start over here by looking at implementation issues and outcome evaluation, saying, what are some of the issues we're having over here in practice? What is it that should inform our research question? That means working together with practitioners and policymakers in defining the research questions, and then going over here, coming back here with a research question, actually doing the research, and then coming back and actually adjusting the intervention. So rather than thinking about it linearly, getting research into practice, you think about it cyclically, getting your research questions out of practice, and therefore with the hope of getting much more bigger, more relevant questions and better acceptance of your results when you come back a couple of years later. Another aspect about systems thinking is that you should think about how complex systems are. One of the few examples that I'm aware of actually thinking about systems is from a British report called the Foresight Report on Obesity, which looks at obesity in a British context and says that the heart of this is, of course, the energy balance. The fact that it's easy for me to get food, there's lots of food around, and I eat more than my physical need, so that I have a positive energy balance, and therefore I gain weight. Of course, this can be moderated by my tendency to store energy based on epigenetic or genetic programming, etc. Also about my conscious control of my appetite and how I eat, and how hard it is for me to change my habits. So already now it's complex, but if we then put on another layer, thinking about the systems, repercussions of and determinants of these inner circles, you'll say that the picture looks much more complex. The fact that the positive energy balance is here in the middle, it has to do with physiology, but it also has to do with physical activity and the architecture of society, public transport, how buildings are constructed, where is the staircase, where is the elevator. It has to do with my individual psychology, it has to do with social psychology in society, and it has to do with food production and food consumption systems. By now, it's easy to despair a bit and say, but if things are so complex, how can we maneuver in this system and how can we create knowledge? Well, maybe not all of these connections are equally important. They went on in this report to actually try to weight the more important relations, and you'll see them as heavier arrows in this picture, and you see that you end up a lot over here in the food production and food consumption systems, some in the architecture, social planning, etc., and to some extent in the physiology. Now, this obviously has implications for the way we should think about research, the way we should design our evaluations, and report on them. Another example is actually from this book, where we can't read the title, but it says Improving Health System Performance in Poor Countries. It's a book by David Peters, and they've actually looked at how strategies are implemented and their odds of successful implementation, making a change of something, and found that if you now look at randomized controlled trials, the odds of success, and all adequate studies, meaning also quasi-experimental studies, etc., if you're not just implementing but also build in community coordination and organization in your intervention, the odds ratio is 4.6 compared to if you're not doing that. If you do local adaptation of your intervention, you'll see that the odds ratio is somewhere between 9 and 4. There is no magic bullets. Let's look at the local context and adapt our intervention to the local system. If you bother to go out and consult various stakeholders for your intervention and get their support, your ratio is almost 4. If you consult and engage interest groups, you'll see you're around 3 to 4 on odds ratio. Flexibility and modification through stakeholder feedback, that is, we're not having a fixed intervention, we're rather pragmatic and we're changing it as we go along. Again, higher odds ratio. And representation from interest groups, and as you can see here, constraint reduction plans, i.e. we hit the snag, what can we do, how can we mitigate that? Again, odds ratios of 6.7 and 2.7. In my reading, and examples are saying that if you just not concentrate on your technology or a singular intervention, but you actually look at it from a systems perspective and you address several of the building blocks in the health system, the odds of success for your intervention are much higher. So, returning now to the health system building blocks of WHO, how many of these building blocks are typically reflected in evaluations? An illustrative literature review, which is published by the Alliance for Health Policy and Systems Research in 2010, they took a random sample of the literature, and actually they looked at published and grey literature, as you'll see, and whether an evaluation of an intervention addressed only health service delivery. You'll find that 23% of published literature dealt only with that. 20% looked only at aspects of health workers. 14% only at information. 11% looked at medical technologies and drugs, etc. 15% dealt only with financing, and 16% only with governance. Taking in the grey literature, you'll see that health financing seems to be reported more in the grey literature than in the published literature. But the picture doesn't change a whole lot. In total, 65% of the evaluation of the articles actually drawn in this sample dealt only with one health system building block. That is, had a poor conceptualization of the health system and systems thinking. They continue then and looking at whether out of the 192 studies studied here, they addressed 2, 3, or 4 of the 6 building blocks. And you'll see that 62 of 192, a bit less than 30% actually looked at more building blocks. But if you want to look at the whole system, taking into the full complexity of 5 or 6 blocks, almost no evaluation study takes in the full complex health system. This, I think, as we think about the future, reforming health systems and answering questions about how to do something, how to scale something up, rather than what to do, is an important shortcoming of how we design our studies and how we go about doing health systems research. So, in conclusion, I'd like to say that health systems have interconnected building blocks. Understanding their reactions and interactions are key in designing and evaluation of interventions, certainly on the supply side in the health system itself, or health service delivery rather, but also that we need to think systems when we design, take into account the demand side, i.e. our customers. So, think complex, think systems. Thanks a lot.